Hi class, we're back again for another lecture and you guys know the drill. You gotta first get your mind right and your heart ready. So let's go. Let's get pumped up. All right, we ready? So the objectives we're gonna cover for this lecture will be to name the four walls of the left ventricle. We're gonna name the leads that look at each of the four walls of the left ventricle. Describe an easy way to find the posterior MI. Name the coronary artery that feeds each of the four walls of the left ventricle. Describe how to determine if a right ventricular infarction is present. And describe the precordial lead placement for a right-sided EKG. So did you know that your right ventricle was much thinner than your left, and why? Well, your left ventricle pumps blood from the heart to the rest of the body. Thus, it needs to be more muscular and stronger. The right ventricle pumps blood to the lungs, which is nearer to the heart, so it doesn't have to be as thick. So here's a recap, an illustration of your ST segments and intervals for a healthy person versus a person who's having a heart attack. Here we're looking at an anterior wall MI, and what it's showing you here is that significant Q wave that you'll see on the EKG, as well as the inverted T. Okay, so let's talk about the location of the four walls of the left ventricle and which leads you look at to determine what MI occurs in that area. So in V1 through V4, you have an anterior MI, leads 1 AVL, V5 through V6. We'll look at the lateral wall, leads 2, 3, and AVF, looks at your inferior wall. And then there's no direct lead orientation to for a diagnosis to be made for a posterior MI. Okay, so in order to do that, if you look on page 318 of your text, you're going to be looking at the reciprocal changes in order to determine your posterior MI. So if your anterior MI is looking at in V1 and V2, well, then you look for the posterior MI opposite of that, and you should see the opposite changes. For example, if there's T wave inversion with your anterior MI, then the opposite of it, if you have a posterior MI, then you're going to have your T wave is going to be upright. Okay, and as well as if you have the ST elevation with the anterior, well, in the posterior, you'll see ST depression. Okay, and again, you can see another illustration of that on page 318 of your text. Here's just another view of the heart from the outside. For example, when you have the leads placed for your 12 lead EKG, it just gives you a view from the outside, which lead is looking at which wall of the heart. So identifying a myocardial infarction by location, your 12 lead EKG can help you identify which coronary artery or branch is occluded, as well as the area of the heart which is ischemic, injured, and or infarcted. So leads 2, 3, and AVF provide a view of the tissue that's supplied by your right coronary artery, whereas leads 1, AVL, V1 through V5, and V6 view the tissue supplied by your left coronary artery. Okay, here's another visual of the walls of the left ventricle. Here you see that your anterior wall, your lateral wall, inferior wall, and then the opposite side for your posterior wall. Okay, so this is what's called your infarction squares, and we'll talk about that a little later. However, it still shows you the same thing, your four walls of the left ventricle, which leads you'll look at for those for those locations, and then which artery supplies that area of the heart. So with your right ventricular infarction, uh, that occurs when your right coronary artery system is blocked with damage that extends all the way into the right ventricle. Your right ventricular infarcts are not detectable by your routine 12-lead EKG because it looks at the left side of the heart. There are two conditions that must be met in order to diagnose the right ventricular infarction. One, you must have EKG evidence of an inferior wall MI on your standard 12-lead EKG. And then two, you need to have a right-sided EKG that reveals ST elevation in V3R and or V4R. The right-sided EKG is only done if the doctor suspects a right ventricular infarction. So you won't do, if you just ordered an EKG, then you're going to do your normal routine 12-lead EKG with your electrodes on the left side. You will only do a right-sided EKG if the doctor specifically asks for a right-sided EKG. Right-sided EKG is done with the precordial leads placed on the right side instead of the left, but your limb leads will remain in the same place. And here's an illustration of that. Here's your left-sided lead, and here's your right-side leads. They'll be in the same area. You'll use the same landmarks, only it'll be on the right side. And here's another illustration of that, as well as a breakdown of where the actual, the intercostal space is. Now, so you can just relax, okay? Don't worry, you guys are not going to have to, in your clinical setting, you're not going to have to diagnose the patients, okay? You're not going to have to tell the doctor that this patient's having an inferior wall MI, or whatever. You're just going to need to recognize the changes in the EKG, okay? So that you are aware that you need to notify someone quickly if you see those changes, okay? So now for your assignment, you're going to create your reference card or reference sheet of the infarction locations, the EKG changes, and the coronary artery that supplies those areas. And you can see an illustration of that in table 14-1 on page 319. And I will see you guys next lecture.